Hello, everyone. I'd like to welcome you to this event. I'm so glad that everyone is here. And I would like to ask if you don't mind turning on your video so that I can see your faces. And that way I'll be able to get some feedback, whether things are clear, and if anyone looks like something needs a little more explanation, I'll be able to do that. I'd like to introduce myself. My name is Dr. Suzie Bergman. I know some of you, and then others are new to me. We have people from around the world, and I would like to thank those who are mentors of mine who have gotten up early in the morning in their part of the world to be here. And I also would like to point out that we have dentists, dental students, we have some oral and maxillofacial surgeons, some orofacial pain specialists, and then dentists who primarily do ortho or are learning orthodontics. So it's a very broad array of people here, and I'm excited to talk about a topic that is very important to me. It's orthodontic considerations for the patients with TMD, or as I like to say, is ortho okay for the TMJ? So just for those of you who don't know me, my name is Dr. Suzie Bergman. I go by Dr. Suzie. I went to dental school in West Virginia. I graduated in 1994. And I also studied at Progressive Orthodontic seminars where I graduated in 2011. So once I learned orthodontics, dentistry changed for me in really remarkable ways. I absolutely love to talk about ortho, and I'm also a TMD patient, so that is another thing that I have gotten very, very familiar with, and I treat a lot of patients with TMDs. I have a private practice with my husband, and we live in Vancouver, Washington, in the Northwest of the United States. I teach for Progressive Orthodontic seminars and the McGann Postgraduate School of Dentistry, which is where I am right now at our headquarters. And I'm also an honorary program advisor and faculty member for the TMJ Foundation Fellowship, which is a global consortium hosted by Dahmer, India. I'm also a visiting scholar at OHSU in the neurosurgery department, where I'm working on a really exciting research project about the differential diagnosis between temporomandibular disorders and trigeminal neuralgia. And I have no conflicts of interest. So let's get started. We're going to talk about TMD, so we need to know a little bit about the joint that we're discussing. And I think that the TMJ, the temporomandibular joint, is one of the most incredible parts of the human body. It is the only joint in the body that is connected on both sides. And so if one side is moving, the other side has no choice but to also move. So let's talk a little bit about what is TMD. So temporomandibular disorder is the term that's most commonly used, although you will hear people saying things like TMJ or TMJD, but these are a complex group of conditions that cause pain and dysfunction in the jaw muscles, the temporomandibular joints, and the nerves associated with chronic facial pain. Any problem that causes orthopedic instability in the masticatory system can lead to TMD. So as dentists, we are actually orthopedists because we are affecting the stability of the masticatory system. Now, the question that we are asking today is, should you do ortho on patients with TMD? So some of you are probably saying, yes, absolutely, we should do ortho on patients with TMD because our ortho can get rid of the patient's disorder. And then some of you are probably saying, absolutely not. I would never touch a patient orthodontically that is complaining of pain in the jaw joint. I don't want to make it worse. And then there are probably quite a few of you who are saying, I'm not sure where I stand on this. So that is probably why you're here today, right? So let's look at these questions. We have several questions that we need to answer. The first one is, how should we evaluate our patient? Well, the first thing that we need to do is ask our patient, why are you here? Why have you come to see me today? If the patient is complaining of some type of pain, then we need to know, is this new pain? Is this pain that has become chronic? What have you done for your pain? Who else have you seen? And what are your expectations? So we never promise patients that we can get rid of their TMD symptoms with our treatment, because that is setting unrealistic expectations. But we also must do a very thorough evaluation before we start the case so that we know where the patient was at the beginning, and that at the end of treatment, we want to have either made their symptoms better or definitely not made them any worse. Now, what are your goals and your limitations when you're treating ortho patients? Well, the first thing that I want to point out is that we need to have goals and limitations for every ortho patient, not just the ones that are being treated that have temporomandibular disorders. So here at Progressive Orthodontics, where I'm teaching, we have a section in our software that is specifically dedicated to us documenting our goals and limitations so that we know before we start where we want to end up. Now, the next question that we have to ask is, who is a good candidate for ortho? Obviously, a patient who is symptomatic is not a good candidate, right? Just like we have patients who have periodontal disorders or periodontal disease, we do not move their teeth in the presence of inflammation. That's contraindicated. So same thing, we do not want to start with a patient who's symptomatic and unstable and do something that may make their symptoms worse. Now, if we have a patient who comes in and they are complaining that they have a click or a pop, but the click or pop isn't painful, that's a different story. And we're going to talk about that more later. Now, what should you do if symptoms arise during treatment? That's another consideration. Perhaps you have started ortho on a patient who feels completely healthy and their jaws don't bother them at all. And then while they're in treatment, they come in and they say, you know, those rubber bands that you gave me, they really, really make my jaw hurt. I don't want to use those rubber bands anymore. Should you panic? Should you take the braces off? No, that's not necessary. I'm going to give you some ideas of how to manage a patient if they have symptoms that arise during treatment. So in this presentation, you're going to see some slides where you see classification or part of the exam that comes from our software. We have amazing software that we use here at Progressive Orthodontics seminars. It's called SmileStream software, and it's actually free to any dentist anywhere in the world. So if you have questions about the software, my colleague Yassine is here with us today, and you can put questions about our program or SmileStream or anything that you would like more information about, and he'd be happy to share that with you. So when we're doing our evaluation of our patient, the most important part of evaluating a patient is always the history, okay? When we listen to the patient, there's a famous phrase or quote that says, if you listen to the patient, he or she is telling you the diagnosis. So before we get started, we need to ask questions, and we need to ask the right questions. It's very important for us to document before we start if we observed normal function. And if not, we need to be specific about what was not normal in the patient's function. So if they have clicking, we need to know whether it's on one side or both sides, if it's early or late or both clicking, because these mean different things. And in the amount of time that we have here this evening, or whatever part of the day it is for you, we can't get into all the specifics, but we have lots of resources for you if you would like to learn more about this. Another thing that we need to talk about is whether or not the patient has pain in their ears or ringing or fullness in their ears. And we need to ask the patient to open for us so that we can watch and see if their jaw deviates, and if it deviates to the left or the right. Sometimes the jaw will make an S pattern, and sometimes it will actually deflect, and those both mean different things. So we need to document. Also want to know how wide the patient is opening. If a patient is opening less than 40 millimeters, that should be concerning to us, because even a 3 or 4-year-old child should be able to open about 40 millimeters. If the patient's only opening 20 millimeters, then we certainly don't want to be doing dental treatment of any kind on them, and including orthodontics. And then another thing that we need to ask the patient is about headaches. How often do they have them, and where are the headaches? So when a patient comes into our office, they're going to come in requesting ortho, and they're going to say, Doctor, I don't like the way my teeth look. You hear this one a lot. I have this one tooth right here that sticks out too far, or I don't like the crowding down here. And that's an aesthetic consideration. And the majority of orthodontic patients are coming in for aesthetics. But sometimes we have patients who are coming in and saying, you know, doctor, when I try to eat food, I can't chew properly. I have pain. I want you to make my teeth fit together better. And that's an issue of function. Then you'll sometimes have patients who have both going on. They say, I don't like the way my teeth look, and they're not comfortable. It's really hard for me to use my teeth the way that I need to use them. So when the patient comes in and tells you that they would like to be treated orthodontically, and that they have, maybe they have some concerns with their jaw, how are you going to treat the patient? Well, like I said, the first thing that you're going to do is you ask the patient why they're here. And then you get their answer, whether it's aesthetics, function, or both. And now you're going to take a history. And I'm sure some of you have probably heard this acronym. And those of you who've been students in my POS classes know that I love acronyms. So I have this acronym, OLD CARTS, and it is onset, location, duration, character, aggravating factors, relieving factors, timing, and severity. Let's look at each one of these, okay? So onset, when did it start? Was there a specific injury that the patient sustained? Did they have a blow to the head, a macro trauma, a car accident where they had whiplash? Do they remember being eating something and having their jaw kind of get stuck or catch? Those are questions that are important for us to ask. And then location, we need to know where the pain is. We need to know if it's on one side or both sides, and if it's traveling, if you put pressure on an area, if they feel that pain in another area, that's referred pain. And then the duration of the pain. Some patients will say, you know, what happens to me is I wake up in the morning and I can't open my mouth very wide, but then I get up and I start to brush my teeth, I hear a loud pop, and now it hurts when it pops, but after that, I'm fine for the rest of the day. Or you'll have other patients who say, well, my jaw really bothers me more as the day goes on. When I eat, when I talk, when I use my jaw, it gets tired. And these are things that we need to document. Then we also need to know what type of pain they have. What is the character of the pain? If it's burning, if it's electrical, if it's short-lived and stabbing and it's only on one side, it's possible that this isn't a TMD at all. So we need to know if the patient says that their pain is dull and aching, or if it's like a muscle spasm, what type of pain they're feeling is very important. And then we want to ask them what aggravates their jaw pain. Is it aggravated by use? Is it aggravated by temperature? What are the things that make it feel worse? And on the flip side, what are the things that relieve the pain? Maybe the patient says, well, when my jaw bothers me, I just take a little Aleve and then it feels better. Or they might say, I have to sit with ice and I have to be quiet and I have to rest it. And then you want to know what the severity is. So is the patient in so much pain that they can't perform their daily functions? Or is this something that's just kind of an annoyance to them? You can use the visual analog scale, or you can have them tell you mild, moderate, or severe. And what is the timing of their pain? Is it worse in the morning? Is it worse when they've been stressed out studying for exam? Maybe they're clenching. Those are all the questions that are part of the old CARTS acronym. And then in our office, we have a screening questionnaire that we give to our patients. And sometimes we will just ask our patients questions like, has anything changed in your health history? Or, are you on any new medications? And we really actually need to stop. When we ask a question to a patient, we should always think about why we're asking this question. So I have my screening questionnaire. I'm going to go through with you quickly, and we'll talk about why we're asking these questions. Let's say we ask the patient if they have pain, stiffness, or fatigue in their jaw from chewing, talking, or at dental visits. And the patient says, yes, you know what? Every time I go to the dentist, it really hurts. And when I have to hold my mouth open for that length of time, what can you do for me, doctor? So obviously we know, those of us who are dentists, that there are things we can do for our patients. We can have them take some anti-inflammatory medication before an appointment. We can give them breaks during the appointment. We don't want to put in a bite block that's too big for them. If the patient says that they have pain when they're chewing or talking, then we can give them some recommendations. We can tell them, if your pain is from chewing, then you want to take smaller bites, you want softer foods, and you want smaller bites, softer foods, and slower chewing. So I call that the 3 S's. And then the reason that we're asking the patient about that type of discomfort is because we need to know what is causing it. So it could be caused by stress, anxiety, inflammation, injury, bruxism, or overuse. And the treatment is going to depend on what the cause of the discomfort is. Another question that we're going to ask them is, does your jaw ever get stuck? Does it catch? Does it lock or go out? And when does this happen? Does it happen when you're opening, chewing, or yawning? So one of the things that we can teach our patients is that yawning can actually cause subluxation or dislocation in a hypermobile patient. And that's very scary for the patient. So if a patient says, I'm really afraid to yawn or open my mouth wide, you can just teach them to put their chin towards their chest, and that will allow them to not open quite as wide. And that's something that we want our patients to be able to do so that they don't have to have a maneuver done for a subluxation. If they have had it, a dislocation happen in the past that they weren't actually able to correct themselves, then they've probably shown up in an emergency room or maybe a dentist's office, maybe even your office. And I don't know if any of you have ever done this, but we would have to help the patient get the joint back into the proper position. And we would do that by putting our thumbs on the molars. It's a good idea to put some gauze around your thumbs before you do this, and put the fingers underneath the chin and tell the patient to try to relax. And then you are going to have to manipulate the jaw until the joint goes back into place. Another question that we're going to ask them, does your jaw make sounds? Does it make clicking, popping, or grating sounds, or has it at any time in the past? And are those sounds on the right side, the left side, or both sides? And another thing that is not clear to everyone is that when sounds stop, that's not necessarily a good thing, because that could mean that the patient now has a disc displacement without reduction. So sounds that are just sounds without pain are not concerning, but sounds that are accompanied by pain are definitely significant, and we need to know about them. If the clicking has stopped, then we need to think there may be some degenerative changes in the head of the condyle, and there may be some disc displacement. There needs to be more investigation. This patient, as you can see, has some changes in the head of their condyle, and they could only open at 20 millimeters at the time that this image was taken. We want to ask our patients if they know, or if they've been told by like someone who sleeps next to them, that they clench or grind their teeth at night, or perhaps they clench during the day. And if so, then we can teach them to put their tongue up to keep their teeth apart. And that's another acronym that I like. It's TAT2, teeth apart, tongue up. Now, why are we asking them about bruxism? Because there are things we can do to help them. So if you take one of our courses that teaches about the actual treatments that we can offer our patients, you'll learn about things like using something to disclude the teeth, whether it be a temporary type of discluder or a custom made occlusal guard, or we might give the patient some Botox for these treatments. Now, when it comes to ortho, it's really nice because if our patient is in treatment, we don't want to have to take things off to give them this type of occlusal guard. So we can give them something called an aqualizer, which is just two little fluid filled pads. And this little part of plastic goes up underneath the lip, and then the brackets and bands can stay where they are. Now, another thing we need to ask them is, does your bite feel strained or uncomfortable? And why do we ask if their bite feels strained or uncomfortable? This patient, if you look at where the teeth are contacting, you see that there's no contact in the posterior teeth. So when they bite down, they have to squeeze, and that's loading the joint. And loading the joint is something that can become a risk factor for patients if they're loading too much, if they're grinding, clenching, biting on things that are really hard. And so we need to know if their bite is uncomfortable to them. This is also usually an uncomfortable bite, because in a situation like this, which is an orthodontic class 2 division 2 case, when the patient is biting down here, they're putting pressure on the lingual of the upper teeth, or sometimes even on the gingiva up there. And if they squeeze their teeth to try to improve the situation that they're feeling, their condyle can go back posteriorly, and now it's in an orthopedically unstable position. And we're going to talk about that a little bit more later on in the in this session. If the patient has noticed a recent change in their bite, that's also something that we need to understand. The sudden change in the bite is not causing the disorder, but it's a result of the disorder. It could be that they have a crown that's too high. It could be because they're having muscle spasms. It could be that they've had some macro trauma, or they might have some degenerative changes going on. So in a case like this, what we don't want to do is adjust the bite before we know why they have a change in their bite. Oh, sorry. Okay. Next, we want to know, does the patient habitually chew or accidentally bite their lips, cheek, or tongue? Now, there's a lot here, so let's just go through it quickly. If a patient is accidentally chewing their cheek, this could be just because they're chewing and talking quickly, and we need to tell them to slow down a little bit. If they're accidentally biting, that could be because their bite is misaligned, and maybe they do need some orthodontic interventions. If they're biting while they're asleep, then this is unintentional and it's outside the patient's control. So these are the type of patients that might need an occlusal guard. And if the biting is habitual, then that's a habit that is semi-conscious and might require some behavioral modification, like with a therapist. Then there's an actual mental health condition that's driven by anxiety or stress. And it's a little hard to pronounce, so I'll just tell you the initials, BFRB. But that is something that definitely needs referral to a behavioral health specialist. Now, I think that this is probably one of the most important parts of the screening questionnaire, because it says, describe any other pain of the head or neck that occurs on a regular basis. And usually when I get this questionnaire back after my assistant has seated the patient, they've written all kinds of information in here that they want me to know about. So I'm not going to start any treatment, whether it's, just a DO on a molar or comprehensive dental orthodontics, until I have found out if the patient has a healthy, sound masticatory system. Okay, so now we're going to move on a little bit, and I mentioned the SmileStream software that we use here at McGann Postgrad and Progressive Orthodontics. There's a big portion of the software that is dedicated to orthodontics, but there's also a section that's dedicated to the TMJ. And in this evaluation, we asked the patient several of the questions that were in that screening questionnaire, along with some other questions. And we can't go through all of those questions right now, but one thing that I would like to do is just point out some of the things that we need to think about before starting any ortho treatment. There are patients who have had whiplash injuries or motor vehicle accidents, and they've gone in to be examined, and the jaw is often overlooked. That is something that I know a lot about because I had something happen to me when I was a teenager. And when I went into the emergency room, it wasn't discovered, and it went pretty poorly for me, and I've had several surgeries, and I've had ortho several times too. So it's important that we know that there will be a delayed onset of pain, and often there's no outward appearance of damage, but we can have some disc displacements and inflammation and bleeding in the joint capsule when things like this happen. So that's something that we really need to be aware of. We also need to know about headaches, and the type of headache that's called a TMJ headache is one that's usually tight, dull, and aching, and it's usually worse on the side where the TMJ is worse. It's also aggravated by jaw movement and it improves with relaxation. So those headaches are something that need to be documented. That's in our questionnaire about timing and frequency. And then we also need to make sure that we're not confusing a TMD with a sinusitis, which is common, and most of you, if you're dentists, already know about this. We need to ask the patient if their symptoms were gradual or sudden, because if there was a gradual onset, then that indicates that there's been an increase in lactic acid accumulation. If there's a sudden onset, that can indicate some internal derangement of the disc condyle complex. When you ask your patient what triggers pain, you're going to get all kinds of answers, right? It could be from chewing gum, it could be from eating hard, crunchy foods, from clenching, from yawning, opening wide for singing, and those types of activities, and long dental appointments. It could happen when they open their mouth. They could have pain when they're closing their mouth. A lot of people don't realize, but TMD patients have a lot of pain when they cry, because crying uses all of those muscles that are already sometimes tender in a myofascial pain disorder. They could have pain when they're lifting weights or doing activities where they're clenching, if they're stressed out in long car rides, or if they're using bad body mechanics. So those are things that we also need to know. Now, we're going to palpate the patient's muscles during this exam. And I don't have time tonight to teach you how to do all of the palpation, but I do have a good course on alignermaster.com that you can watch. And we also have some other courses that are on demand that you could watch if you want to learn how to properly palpate these muscles. A couple things that I will tell you about them. When you're palpating the masseters and the temporalis muscles, you want to ask the patient to clench so that you can see if there's pain, and you want to do one side at a time. And then when the patient reports the pain, you need to also ask them, is this familiar pain to you? So I tell my patients, if I were to pull your finger and I pulled it really hard, you would say, yes, that hurts, but that's not familiar to me because no one ever pulls my finger. So you want them to let you know, is the pain mild, moderate, or severe? And your assistant, if you're using SmileStream, can just slide the slider to where the patient tells you that their discomfort is. You're going to palpate the neck muscles. You're also going to palpate the temporalis muscles, where you'll find a lot of patients are holding tension in those areas. The cervical muscles are important. A lot of pain that patients have that is muscular in origin extends into the neck. And then you want to palpate inside the mouth, a couple places that are usually not very comfortable for most patients, and especially if they have a TM disorder. The first one is the temporalis at the coronoid. And as you place your finger on the coronoid notch, the patient is going to let you know if that triggers pain. Let's say that they find that that triggers pain behind their eye, and they tell you that's where my headaches are. That is very significant because the patient could have something called Temporalis Tendonitis, which is also called migraine mimic. And it feels like a migraine, but it's actually inflammation of the temporalis tendon, and it can be easily treated. Another one that we do intraorally is the medial pterygoid, and we have to be careful with that one because it can cause the patient to gag if we don't do it properly. Next, you're going to just do some palpation of the joint itself to see if the patient has pain right where the condyle is, and if they're clicking or popping as they open, if they have crepitation. We talked about these already a little bit. And then you want to look at their teeth. you want to, this is the part that starts to be our orthodontic considerations here. So does the patient have an open bite? Is it average, or is it a closed or deep bite? Do they have a malocclusion that's class 1, class 2, or class 3? And you know, we dentists know what a malocclusion is because dentists invented that word. And in 1904, I believe, Dr. Engel came up with the classification. And we're going to talk in a little bit about whether or not a malocclusion is a risk factor for TMDs. But we do want to note how many millimeters on the right and left at the molar and the canine we have an angle discrepancy. Then we're going to watch the patient with their excursions, the protrusive and the lateral excursions. We want them to document how many millimeters they can go and if they have pain when they do that. And we're going to look at their teeth. We're going to determine whether or not they have wear on their incisors or their posterior teeth, and if they have a significant amount of restorative, and if the restorations are in good shape or not. Then we're going to move on to goals and limitations. So this is actually part of our ortho portion and not the temporomandibular portion of our screening. We are going to write down or document what our goals are for the case and what our limitations are that we may find make it not possible for us to correct certain things. If we do this at the very beginning, then there will be no surprises for the patients. And it's always best when we have our roadmap, our treatment plan ready to go before we actually put the first band or bracket on the tooth. So this is a really, really important thing to consider before you get started. Our main goal should be for any ortho patient, and specifically for the patients with TMD complaints, that when we're finished, we've achieved orthopedic stability. Because if all we've done is given the patients a pretty smile, then when they come back and they're having discomfort because they don't have an orthopedically stable occlusion, then we have failed them. So what is orthopedic stability? That would be when joint stability and occlusal stability happen at the same time. So the condyle will be fully seated with the disc properly interposed, and the muscles will be holding the joint in a stable position. That's called musculoskeletally stable. And at the same time, we have our teeth where they need to be. Now, where do the teeth need to be? That's something that can't be covered in this short lecture either, but there's something called Andrew's 6 keys to occlusion, and that's what orthodontists and dentists who do orthodontic therapy have as their goal at the end of treatment. We want our condyle to be stable. It needs to be in the most superior and anterior position in the fossa, resting against the posterior slope of the eminence, with the disc properly interposed between the condyle and the fossa. And then for orthopedic stability, we want to have even and simultaneous contact of all the teeth, with the posterior teeth contacting heavier than the anterior teeth when the patient is in their normal upright position, not when they're laying back in the chair. And we want to have adequate contacts on the working side, with the contacts being heavier in the posterior than the anterior. All right, so now we're going to talk a little bit about some controversies in orthodontics and what we should do. Some of you may be already doing ortho and you may use functional appliances. And some of you may not be doing any ortho or not be aware what a functional appliance is. So I'm going to try to go through this quickly for you. There are some there's a school of thought that if we place the condyle in a forward position, we can grow a mandible. And there are those who say, no, we cannot grow a mandible. And we don't have time to debate that here tonight. But I just want to discuss what happens when we put the condyle in a forward position. Is this going to cause anatomical problems? So the answer is no. This is a functional position. When we protrude, our condyle comes forward, but the muscles must actively brace the condyle to maintain it in this position. So what happens if we put a functional appliance, which is something that's going to go between the teeth and it's going to bring the condyle forward, and we are hoping that while we're doing our treatment, the mandible is going to grow, and this is where the patient's going to finish. But what happens if the mandible does not grow? So the question is, what's holding the mandible in that forward position? It's the lateral pterygoid muscle. And so if the lateral pterygoid muscle is protruded for an extended amount of time, what will happen? Well, this is something called myostatic contracture. And what that means is that when the muscles are not allowed to function with their full range of motion, it will tend to lose its stretch reflex capability, and it will gradually shorten. And myostatic contracture is not a permanent thing. It's reversible. I don't think we can go into all of the details about how that happens, but basically when the muscle is contracting like that, or it's not contracting, it's a contracture, so it's shortened, and when the mandible is held forward in that position, let's say that you finish your orthodontic treatment with that position, but the muscles have been in this shortened state, and then over time they start to lengthen again, because this can happen. And as they lengthen, what's going to happen? The patient is going to develop an anterior open bite. And that's not what we want to have occur. We don't want to have a patient come in and say, doctor, I have this problem. When I bite the way that you finished my ortho, everything looks great. But when I go like this, I'm only touching on my back teeth. That's called a Sunday bite or a dual bite. And that's a big problem. And that's something that we as dentists who do orthodontic therapy don't want to see. So we need to be sure before we take the braces off, if we're using any type of functional appliance, we need to be sure that the joint is in a musculoskeletally stable position. And if that means that the teeth need to be moved around a little bit, we need to do that moving before we take the braces off. Now we're going to move on a little bit, and I'm going to ask Yassine to let me know how I'm doing on time. But we're going to talk about the patients that we have accepted for orthodontic treatment who didn't have any problems during the history taking and the exam that we did on them. During the ortho, they come in one day and say, I'm really not comfortable when I wear rubber bands, or ever since you put this new wire in, I'm just really not comfortable. My jaw's been bothering me. The first thing that we're going to do is we're going to check our progress towards our goal. We have 3 things that we look at to make sure that we're getting to the final desired position. And those are our transverse relationships, our vertical relationship, and our anterior posterior relationship. Now, we also need to let the patient know that they shouldn't be alarmed. This is a benign problem. It's not something that we expect to continue for them once the braces are off. but we need to do some things to improve the situation. So we need to have them decrease their use to within painless limits, just like a person who injured their foot while they were running. We would tell that person, you need to not run as much until your foot heals. So same thing, we want them also to eliminate any habits that they have that are parafunctional in nature, like biting their fingernails or biting a pencil, too much gum chewing, those kind of things. And then, like I said before, the teeth should only be in contact with each other when they're chewing, swallowing, or speaking. So patients need to know that when they're not doing any of those activities, their teeth should be apart and their tongue should be up, and it should be lightly suctioned in the roof of their mouth with the tip of the tongue against the upper incisors. All right, so when the patient comes in and says that they're uncomfortable, you can consider giving them an occlulizer. That's usually what I start with. And then maybe some analgesic medications or a muscle relaxer to take at bedtime. We don't want young patients taking muscle relaxers or people taking them in the morning if they have to drive or operate heavy machinery. So I usually prefer to start with NSAIDs. Reevaluate them in a week, and if the symptoms are resolved, then we can continue the treatment. If the symptoms are not resolved, then we should consider temporarily taking the elastics away, just take them out of the picture. And sometimes what we can do is just wait about a week, and then we can resume the elastics and maybe use a lighter elastic if necessary. Or like I said, I usually start with this. We can give them an occlulizer so that they can wear it to disclude their teeth at night. Now, after discluding the teeth, you're going to wait a couple weeks. And if the symptoms are resolved, again, you can continue with your treatment. But what if the symptoms are not resolved? Then you need to consider maybe removing the appliance and fabricating an occlusal guard. Or you need to also, I wouldn't say but additionally, you need to assess for other possible reasons that the patient is having this discomfort. Have they been in any type of accident? Are they studying for finals? Are they working in a job that's very stressful? Are they having some problems in their relationship? Do they clench and grind their teeth when they're concentrating at work? Or are they having some family difficulties? Do they have a long commute to work? All of these things can be the possible reasons. And so you shouldn't always think, oh, it's the braces. You need to find out what is contributing to the discomfort in order to know what you can do to resolve it. Now, there are a couple of different hypotheses for how pain is perpetuated in a TMD patient. And this used to be the common thinking, that it was a vicious pain cycle. So we believed that trauma or stimuli or anything that caused a muscle spasm would cause there to be an accumulation of waste products and less oxygen, and that this would make changes in the chemical changes in the muscle, and lactic acid would build up, and then the patient would have spasms because of that, and then the spasms would cause the pain, and it would just continue in this vicious cycle. But actually, this is not what we believe anymore to be accurate, because it's not supported by data. And the pain adaptation model is much more scientifically sound. There's data that backs it up. And the pain adaptation model basically tells us that when we feel pain, the muscle response is to try to reduce force, reduce velocity and displacement, so that we are not putting as much force or loading to try to decrease the pain that we have. And that's another topic also. But what's interesting about this is that the way that we used to think about TMD was that it was all about occlusion. And over the years, there have been a lot of doctors who still have held on to that belief that, oh, what I need to do is just make the teeth fit together properly, and then the pain will go away. And actually, now we know that pain is a much more complex concept. And there's a very big difference between pain that is acute, pain that's nociceptive or is from a stimulus, and pain that is chronic. So chronic pain is actually considered a condition. It is a disease, and that's a very interesting topic to me. And if you all want to know more about that, I would highly recommend Dr. Jeff Oakson's lectures on this subject. And he has a textbook that I'll be showing you at the end of the presentation. But the bottom line here is that really pain is more about the adaptability of the individual than it is about things that we used to believe in the past, like the vicious pain cycle and the equilibration of the teeth. So let's look at some research that will help us answer some of the questions that we have about orthodontics and its relationship with TMD. So the first question that a lot of people ask is, does orthodontics cause TMD? And I have some research here also shared by Dr. Oakson. The first study that was done in 1980 looked at 75 patients that received orthodontic treatment and 75 control patients, or patients who did not receive orthodontic treatment. And they followed these patients for 10 years. And what they found was that there were no significant differences in the patients that received ortho and the control group. And then if you look at the rest of these studies, same thing, there is no significant difference. So basically, we hear people say ortho causes TMD, but the literature does not support that. The next thing that we ask sometimes, and I'm sure you've all probably heard this, because there seems to be trends in orthodontics, just like there are in other areas of dentistry, where it used to be 4 on the floor, they called them, right? 4 bicuspids, and some orthodontists would do all their ortho treatment by taking out bicuspid teeth. So then people started to say, oh, all of these patients who are having TM disorders are having them because they had their arch collapsed and they should have never had the teeth extracted. But these are some studies that were done that showed that the extraction patients and the non-extraction patients were followed for years. And there, again, were no significant differences. So even though people say, yes, extraction should be avoided, that's not supported by the data. And another thing that I like to point out is that if you go to an orthodontist office and they say, we never extract teeth, I would advise you to get out of there. If you are taking your kid to the orthodontist down the street and they say, we always take teeth out, I would also advise you to get out of there. Because what does that tell us? That tells us that the orthodontist or the dentist treating the patients orthodontically isn't really thinking about the patient. They're just saying, this is the technique that I like to use. And that is absolutely never the right thing to do. And in our program, Progressive Orthodontic Seminars, it's a very extensive, comprehensive training. It takes about 1.5 to 2 years to get through. And we teach our doctors to think extraction versus non-extraction. We have software that helps us look at visual treatment objectives to see what would happen in each scenario so that we can decide what's best for the individual patient. They're going to get an appliance that is designed specifically for them, and they're going to get a treatment plan that is designed for the goals of their treatment. Because just saying, like I've heard some ortho friends of mine say, well, I think I'm just going to expand this patient and see what I get, and then I'll decide what to do next. And that's not a good way to approach orthodontic treatment. Another thing that people who are anti-extraction will say is that extraction causes posterior displacement of the condyle. So here's another set of studies that show patients that had primarily bicuspid extractions, and the control group here were non-extraction, and they found that there were no significant differences in the position of the condyle. And then this is a really interesting one that was done by a resident, and he had 42 patients, but he had no controls because he actually had all of these patients come back, and he found that 70% of these patients who had bicuspid extractions, their joints were more forward after the ortho. So that again tells us that that ortho does not cause posterior displacement of the condyles. Now, the next question, of course, that we're going to ask is, does ortho prevent TMD? Because wouldn't that be great if we could just tell all of our TMD patients, well, I know what to do, I'll just do ortho on you, and then you'll never develop TMD in the future. But unfortunately, that question was answered by the first set of studies that I showed you. It said ortho or no ortho, no significant difference. So the take-home message there is ortho doesn't cause TMD and ortho doesn't prevent TMD. But what are we to determine from the research, the data that we just looked at? Are we going to say the studies are all true and there's no relationship between ortho and TMD? That would be something that you could say, well, I looked at these studies and this is what I read, so that must be the bottom line here. But there are other things that we need to consider in order to really be good scientists and really be good interpreters of the literature. One of the things is that the studies only looked at well-controlled orthodontic therapy. And what do I mean by that? The ortho that was being done in a university setting, and there were instructors who were coming to check the work that was being done, or the instructors were doing the ortho. So it was very, very good treatment. And the studies only looked at young adaptive growing patients. Well, one thing that we know is that young adaptive growing patients are done with their ortho before the condyles have completely matured. So the ortho provider can put the teeth into the position that they want them to, and then the nice young adaptive patient can get used to that position. So what are we to really take away from the studies that we just looked at? Orthodontic therapy does affect occlusion, but the relationship is still unclear. And why is that? Why is the relationship unclear? To answer that question, we need to go back to the etiology. What causes TMDs in the first place? Well, there are a lot of etiologic factors, and some of them that we know are stress and genetics. Occlusion is only one of those factors, so we can't say that occlusion is the whole thing here. And then, like we've been talking about, adaptability of the individual comes into play. And if the patient has had an acute TMD, it might be resolved. But if it's a chronic condition, it's going to continue on, and it's going to be much more difficult to treat. And then the longer that the patient has pain, the more central mechanisms are going to be applied. So we can't just look at occlusion and say that that's the whole picture. There's something called a stable malocclusion. So if we look at these patients, and you ask me, which one of these patients is going to be most likely to develop a TMD? My answer to you is going to be that I can't tell you that until I know what the joint position is. If the joint is in the correct position, in its seated, its musculoskeletally stable position, and when the patient bites down, they have all kinds of contacts. They're able to function with the bite that they have, then their malocclusion is just that. It's a malocclusion. But if I have a patient like this one right here, who maybe is going to have to load, the loading is the part of the picture that makes a risk factor for us. If the patient loads to the point that they can't adapt anymore. So is it the deep bite patient? Maybe, maybe not. Is it the patient that has an open bite, or the patient that has a cross bite? We don't know that until we know what their joint position is. And so if we put the patient using the bilateral manipulation technique into their musculoskeletally stable position, then we can take a look at where the teeth are, and that will give us a much better idea of where the instability is in the patient. Now, the next thing that I want to share with you is that in our program, Progressive Orthodontic Seminars, we have over 150 treatment plans, and each of these treatment plans is for a specific scenario. One of the special circumstances is a TMD case. And so I just want to really quickly look at that for those of you who are either students in our program or interested in becoming students in our program, or if you would just like to know my philosophy from the education that I've received. And so, as I said before, we don't know that the deep bite patient is the one who's going to develop temporomandibular disorders, but it is common to see a deep bite and a temporomandibular disorder. And so one of the things that Dr. McGann says is that in general, and this isn't an always or never, it's just in general, bite opening mechanics are favorable in TMD cases. If we're allowing an easier, allowing the mandible to move more freely, that's in general favorable. We want to try to avoid protrusive interference because we don't want the incisors to detorque and the bite to deepen. So that's why we have to decide, are we going to treat the patient extraction or non-extraction? If the patient is already starting out with a deep bite, we don't want to take more teeth out and make the bite even deeper, because we see this when we're retracting upper incisors, like in a skeletal class 2 case. So a skeletal class 2 case is where the upper teeth are much further, or the upper jaw is much further forward than the lower jaw, and the teeth need to try to come together, so we don't want them to detorque, okay? The protrusive interference is going to prevent the mandible from being able to move freely, so it's going to be like the lower jaw is in jail. Skeletal anchorage is something that we can use, which is bite plates, bone plates, sorry, and screws that can be applied to prevent or correct a deep bite and to add torque to the upper incisors. So when I say add torque, that means I want to allow the upper incisors to come forward, which will not only help improve the deep bite, but it will also allow a better inner incisal angle of the teeth. Now, I just want to say we don't really use the term splint very much because splint isn't really what an occlusal guard or occlusal appliance is, but an occlusal guard, if it is successful, it's only establishing which reported symptoms are related to the dental complex. Okay, so if we want to use a flat plane occlusal guard before we start ortho, that's a really good way to try to see, can we get some stability with plastic before we start moving the teeth around? Okay, and what we're going to fabricate is a flat plane occlusal guard with one point of contact per tooth. Okay, that enables the mandible to move freely in every direction. And this is going to help us determine if the occlusion is related to the reported symptoms. So as we're starting to wrap up here, what we want is a step-by-step approach. Every time the patient has symptoms, we want to evaluate what we're doing and how that affects their symptoms. We want to look at treatment versus management. So as a patient's symptoms become more chronic, we don't want to say, we're going to be able to treat you and heal you and you're going to be completely better. We're going to tell them that we want to try to manage things for them. And by setting the expectations, we're telling the patients that we don't expect all of their symptoms to go away, but we hope that we can improve their symptoms. And at the very least, that when we're finished, that we've given them a more stable and orthopedically stable, musculoskeletally stable position. Now, another thing that I want to talk about really quickly before we finish up is that the retainers that we use in orthodontics, we generally use clear overlay retainers in the majority of our cases. But as I'm sure you can probably imagine, this is not a good idea for a TMD patient, because what is this doing? This is discluding the teeth with plastic on the top and plastic on the bottom. So these patients often do better if they have a Holly retainer, the type of retainer that was used a lot more in previous generations. And one of the nice things about a Holly retainer is that if there are teeth that aren't completely seated at the end of ortho, if there isn't maximum intercuspation, the Holly retainer will allow those teeth to allow the bite to settle a little bit, whereas these types of retainers will not. Oftentimes what I do with an ortho patient is I'll give them a clear overlay retainer to wear during the day and a Holly retainer to wear at night on one arch. And then I'll give them maybe a Holly on the other arch for the first 6 months. And then once they're going to nighttime wear, we can consider whether we want to continue them with the Holly retainer or with an occlusal guard. So that's also a topic that we can't cover too quickly in the amount of time that we have left here. But I did want to tell you that I would be more than happy to help any of you who have questions about any of your orthodontic or TMJ and occlusion type cases. I do consulting for progressive orthodontic seminars. I also am involved in the TMJ Foundation with Dahmer, India. And I don't know if my email was provided to you, but Yassine, could you put it in the chat for them in case anyone wants to email me with questions, or you can just reach out to POS and McGann Postgrad, and they can give you my information. I would like to recommend 2 books if any of you are interested in learning more about the topic that we talked about tonight. One of them is Dr. Oakson's Management of Temporomandibular Disorders and Occlusion, and the other one is Dr. Bhargava's book, Temporomandibular Joint Disorders, which is it's written for all dentists. It also has quite a bit of information for maxillofacial surgeons, but it's really, really well written and easy to understand. And it covers so much of what you need to know if you're really interested in treating these cases. So with that, I would like to thank you all for joining us tonight, and we have time set aside for you to ask questions. So please feel free to ask questions, because I want to make sure that if there was anything you didn't get that you were hoping to learn tonight, that we can get those questions answered for you.
How do I do this?
Dr. Suzie,
Yes.
if I may ask something which was maybe not covered on the pace of orthodontics and accommodation of biomechanics during the course of orthodontics, the remodeling part of the temporomandibular joint, if any highlights are there on that topic.
Remodeling of the joint in a growing patient.
In a growing patient where we are undertaking orthodontics simultaneously. As we are changing occlusion, the joint has to remodel along with the changing occlusion during the course of the treatment.
Yes, that's true. So we have people who say that wearing cervical headgear or reverse headgear could have caused some temporomandibular problems. And is that what you're asking, Dr. Darpin? Why they don't, the reason that they don't actually cause the problems that people believe they cause is that the movement is very slow. And as the patient is a growing patient, there's a great deal of adaptability in the system. So if we move slowly and allow the joint to remodel, it will do that. And then when the maximum intercuspation is achieved, then the joint can remodel around that stable occlusal position. Was that your question, Dr. Darpin?
Yes, Dr. Suzie, very well. Because what I see now, people around publicize orthodontics with fast orthodontics and orthodontics with shorter duration. So we're not giving time to the joint to remodel with the pace of changing occlusion, and that's where most of the TMDs set in during the course of the treatment. It is not patients who already have TMDs, but the patients who develop TMDs during the course of the orthodontic treatment. And the major reason currently which we experience around us is the faster pace of orthodontics, which is being delivered to the patient to satisfy the patient. And then eventually the TMDs are growing in those scenarios.
Yes, that's a very good point. Thank you so much for bringing that up. So that is something that there is a system called 6-month smile. Some of you may be familiar with. There are other systems where the patient isn't actually getting their occlusion corrected. They're just getting what we call a cosmetic alignment. And that is definitely something that we want to avoid because we want to move slowly. The way that we avoid problems is to use low force and move slowly and allow the body to keep up with the movement that we're doing. So 6-month smiles, not a good option for patients. Also, like in our system, we usually never take braces off until we've gone through level and alignment, which takes at least 6 to 8 months. And then the mechanics phase. And after that, and the mechanics phase can be an indefinite amount of months, depending on what it is we're trying to achieve. But teeth, if we're closing spaces, teeth move at the rate of about 1 millimeter per month. And then once we have things where we want them, we need to keep the patient in a finishing arch wire for at least a couple of months and allow things to become retentive. So when we do our ortho that way, when we're very careful and we're not taking shortcuts and we're not letting the patient tell us what to do, then we should end up with a really nice, stable result for the patient. But as I said before, we shouldn't be taking braces off if we don't have a musculoskeletally stable joint position. So as we're doing our treatment, if we're concerned about the position of the joint, it's not hard at all to learn how to do the bilateral manipulation to seat the condyles where they belong and take a look at where the teeth are. And when we are sloppy with our ortho, and let's say we finish with a case where like maybe the second molars haven't erupted all the way, but the patient's trying to rush us to take the braces off. And then let's say that the patient does a good job at wearing their retainers. Now we have a problem because maybe they got retainers that were made with second molars that hadn't erupted fully, and they continue to wear those retainers and they stay with a bite where they didn't have full eruption. So those are the kind of problems that I see with taking shortcuts and with trying to do ortho without being fully trained and understanding the relationship between the joint and the teeth. And just for everyone's, just to tell you guys, Dr. Darpin is, he is the founder of the TMJ Foundation online fellowship program that I have had the privilege of being a part of. And he probably knows more about this joint than anyone I've ever met. And it's a huge honor to have you here with us today, Dr. Darpin. I know it's early in the morning for you.
Thank you, Dr. Suzie. It was wonderful facts which were compiled today during the course of this presentation. I'm, in fact, it was a pleasure for me to be here on this platform.
Thank you so much. Does anyone else have questions? I was just going to look through the chat to see if...
Dr. Suzie, good
yes.
morning.
Good morning.
This is Dr. Dheeraj from Mumbai,
Hi
India.
there. How are you?
Very well. Thank you for the amazing presentation. Chat. Thank you so much for the amazing presentation. And cherry on the cake was Dr. Darpan Bhargav's inputs. I just have one question here regarding the presentation, what you mentioned. What to look for in the in the OPG of the patient, or on the orthopantograph of the patient, to see changes which we assume which are happening in the TMJ. So basically I'm talking about the diagnosis part.
That's an excellent question. So we want to take an OPG or a panoramic x-ray on every patient before we start ortho. And we want to look at the condition of the teeth and the joint. And we have to be careful in understanding that there's limited information that we're getting from the OPG because it's not a three-dimensional radiograph, but we can see changes in like the cortication of the condyles. This is going to be more in an adult patient than a young patient, but we can also see things like osteophytes or some type of degenerative changes that are related to arthritis or an inflammatory process and that sort of thing. So we want to take a look at that when we take our panoramic x-ray or OPG. And if we feel that we need further study, then the next thing would be to either get an MRI or possibly a CBCT. And if the patient has active inflammation going on, or they have some issues that need to be resolved before we start the ortho, then we would let them know. I've had patients who get really disappointed when I tell them, you're just not a good candidate for ortho. But it doesn't mean that you can't ever have ortho. It just means that we have to go in the correct order. So we take care of the things that are, we always look at the source of the pain instead of the site of the pain. And we do things in the correct order so that we have a patient who is healthy and stable before we start any orthodontic treatment.
Well, thank you for that answer.
You're welcome.
Good morning, Dr. Suzie,
Good
Dr.
morning.
Suzie Bergman.
Yes,
I'm from India, and I have one question for you.
yes.
You know, in the beginning of the presentation, you talked about different kind of pains, whether it is burning or tingling or dull pain.
Yes.
So I know it's not possible for you to describe all kind of pains and things we can interpret through them. But can you tell me that are they really conclusive in for us to understand that what kind of TMD a patient is having?
Yeah, we sit the person down.
With just the reporting of their the type of pain that they have.
Fine.
Yeah, so I had a patient who kept on saying that, you know, he's got a burning kind of pain or burning tingling sensation. So does it signify something? I mean,
Yes.
are there different? Yeah.
Yes. So TMDs are not generally burning in nature. That might be more of a neuropathic type of disorder. And like patients who have trigeminal neuralgia, not only do they have burning, it's all on one, almost always on one side, not always. There are reports of bilateral, but the majority of them are on one side, and they're very short paroxysmal type of pain. The patient, I've been at the neurosurgery department at Oregon Health Science University for the past few months, and when we see a patient with that type of pain, it just grabs their attention, and it's very fast. It's very, very painful, and then it goes away. So that's a difference between patients that have, like a lot of patients that have a temporomandibular disorder, they kind of have this baseline of pain. So maybe they say they're at a 3 or a 5 most of the time. And then they have these you know, like episodes where they might have a worse day, and they say, well, today my pain was really bad. It was a 7 or an 8, but it's not the same. It's not the same character. So another type of burning pain that we see is, it's actually called burning mouth syndrome. And that's when the patients feel this like sharp electrical pain inside their mouth. And unless we really understand all of these different types of neuropathies and neurovascular pains, then we need to refer the patient to someone who does have training in that area. And even when the doctors have the training, it can be very difficult to get to the bottom of what's going on. So if a patient's having a pain that we don't understand, we have to find the source of the pain instead of trying to treat the site of the pain. And what I mean by that is, like, let's say the patient says that their tooth is bothering them, and you take an x-ray and you look at the x-ray and everything looks fine. But then you ask them, when you lean forward or press on your sinuses, does that make the pain worse? And then you realize this is a sinusitis. So it's kind of, you know, the same concept. The place where the patient is feeling the pain could be referred pain.
So one more question, Dr. Suzie. You know, is it a possibility that person who's having some TMJ problem can develop these neuropathies also along the way? Because that patient
yes.
I'm talking about, he's benefited by the splint,
Mhm.
but at the same time, he's not getting rid of that neuropathic pain that you talked about. And I can see that he has got both the problems, neuropathic as well as TMJ issue. So is it a possibility that neuropathic pain developed because of his TMJ?
Yes, that's definitely, it's a very broad subject, but yes, there are musculoskeletal or myalgic types of discomfort. There are pains within the joint complex itself, and then there are pains that are degenerative in nature, and all of the TMDs are associated with other comorbid conditions. So it's, you know, the neuropathic pain could come from a whole host of problems. It could have come after an extraction that was close to the mandibular nerve. I mean, there's just so many different things that could be causing it. So the testing needs to be done. Sometimes it requires an MRI, you know, sometimes you need to work with a multidisciplinary team and have a neurologist get involved. But it is definitely possible for a patient to have even more than one TMD at a time, and most definitely to have other disorders at the same time.
Okay, thank you. That answers my question very well, Dr.
Great.
Suzie. Thank you so much.
You're so welcome. Any other questions? I was checking the chat really quick. What are your thoughts on the MyoBrace? So that's also kind of a big topic for the time that we have here, but I do believe that epigenetics is it's very interesting, and it makes sense. You know, if we go to the gym and lift weights, we can change the shape of our muscles. So same thing with, you know, a MyoBrace could make some changes. But one thing that I learned early on in my ortho education is the concept of cooperation, especially with young children. And I don't know who said this, but there's a saying, that which can be removed will be removed. So there's a lot of compliance issues. From my colleague who is an instructor here, who's also a pediatric dentist, told me that he used it for a few years, but he had a hard time finding patients that were compliant enough to get the results that he was hoping for. I'm not sure who asked that question. Does that answer your question? Does everyone know what the MyoBrace is? Actually, I should have mentioned before. So a MyoBrace is it's a device that the patient can put in their mouth and use to strengthen and change the shape of the arch while the patient is a growing patient. It's not something that we use in our system here, but we do have other things that we use for for mixed dentition patients to try to get some nice results. And that's one thing that I didn't really talk about much because it's not really the topic that we have here tonight, but some patients will end up having really, really nice results if we work on some of their problems during the mixed dentition phase. And then once they have full eruption, if we've gotten the bones in a better position, upper jaw to lower jaw, rather than like this type of position or this type of position, then we're able to have a very nice orthodontic finish. Other questions? Okay, well, I want to thank you all for joining us tonight. It was really my pleasure to have you all here. I hope that your names were all given for your continuing education. If your name isn't clearly written on the screen, you could just drop it into the chat so that we're able to get you your CE credits. And please don't hesitate to reach out to me. I see that my email did make it into the chat. So I'm very happy to have made acquaintances with those of you who I don't know, and I look forward to doing something like this again in the future. If you have any thoughts about something else that you would like to learn about, be sure to let us know.